There are 5 medical tests that, after 70, can do more harm than good. And the shocking part? Your doctor is probably scheduling one of them for you right now, not out of negligence, not out of bad intentions, but because the system was never designed with your age in mind. What I'm about to share goes against standard medical guidelines. It goes against what most physicians are trained to say. But after 15 years of watching patients suffer the consequences of unnecessary testing, I can no longer stay silent. Stay with me until the end, because the number one test on this list is so routine, so universally recommended, that almost every adult over 70 has had it done. And yet a landmark study found that for patients in this age group, it led to more harm than the condition it was trying to detect. That single test has caused unnecessary surgeries, permanent complications, and in some cases, it has taken years off people's lives instead of adding them. I'm Dr. Patricia Holloway, a physician specialized in senior health with over 15 years of dedicated clinical experience. I've worked with thousands of men and women over 60, and what I see in my clinic every single week breaks my heart. People coming in frightened, having been told they need an urgent procedure, a biopsy, a surgery, all because of a test result that, at their age, should never have triggered an alarm in the first place. What I'm about to share goes against everything the mainstream medical system tells you. But I've seen it with my own eyes, patient after patient, and I refuse to stay silent any longer. If this information already feels important to you, hit that like button right now, because this is the kind of conversation that can genuinely protect your health. Now let me ask you something first. How old are you? In your 60s? Your 70s? Maybe beyond? If you've had a medical test in the last 2 years that led to more procedures, more anxiety, and more medical appointments than you ever expected, type the word "test" in the comments below. You are not alone. And what I'm about to share may finally explain what happened to you. Here's the hard truth about medicine after 70. The human body changes dramatically. The normal ranges established for cholesterol, for blood pressure, for prostate markers, for bone density, all of them were largely developed using data from younger populations. And when you apply those same thresholds to a 75-year-old body, something dangerous happens. You start treating numbers instead of treating people. You start chasing findings that are completely normal for that age and creating panic around things that would never have caused a problem. The result? Unnecessary interventions, unnecessary stress, and a cascade of follow-up procedures that carry their own serious risks. A major review published in the Journal of the American Medical Association found that overtesting in adults over 70 leads to what researchers call a cascade effect. One abnormal number leads to another test. That test leads to a biopsy. That biopsy leads to a procedure. And somewhere in that chain, a patient who was feeling perfectly fine is now dealing with complications they never would have faced if the first test had simply not been ordered. This is not rare. This is happening every single day in clinics and hospitals across the country. And it's happening to good people who trust their doctors and simply want to stay healthy. Here's what terrifies me most. The patients who suffer the most from unnecessary testing are often the most health-conscious, the ones who show up for every appointment, the ones who say yes to every recommended screening, because they care, because they're trying to do the right thing, and the system is taking advantage of that trust. But here's what I want you to hear before we go any further. I am not telling you to stop going to your doctor. I am not telling you to refuse all medical testing. What I am telling you is that after 70, you have the right to ask hard questions. You have the right to say, what happens if we find something? What will we do about it? And is the benefit of knowing worth the risk of finding out? Those are the questions I ask on behalf of my patients every single day. And those are the questions I want you to leave this video prepared to ask on your own behalf. Let's go through the 5 tests. from the least harmful to the one I consider the most overused and most dangerous for adults over 70. Let's start. Number 5. Aggressive cholesterol screening with automatic statin recommendations. Now, I want to be careful here because cholesterol is a legitimate health marker, and statins, for the right patient, are genuinely life-saving medications. But here's where the problem begins. Routine cholesterol panels after 70 often lead to statin prescriptions based on thresholds that were established for middle-aged adults. And what the research increasingly shows is that for adults over 75 who have no prior history of cardiovascular events, the benefit of starting statin therapy becomes far less clear, and the risks become far more real. A study published in the journal JAMA Internal Medicine found that initiating statin therapy in adults over 75 with no prior heart attack or stroke showed no significant reduction in cardiovascular mortality. But what it did show was a measurable increase in muscle-related side effects, including a condition called statin-induced myopathy, which causes significant muscle weakness and pain. In a population where muscle strength is directly linked to fall prevention and independence, that is not a minor side effect. That is a life-altering one. Here's what's happening inside the body. As we age past 70, the liver's metabolism changes. The same dose of a statin that was perfectly appropriate at 55 may accumulate differently at 75, reaching higher concentrations in muscle tissue and increasing the risk of damage. And because muscle weakness in older adults is so often attributed simply to aging, the connection to the medication is frequently missed. What I tell my patients is this: if you are over 70 and have never had a heart attack, never had a stroke, and your doctor is recommending you start a statin based solely on a cholesterol number, ask one specific question. Ask them to show you the absolute risk reduction this medication provides for someone with my specific age and health history. Not the relative risk, the absolute risk. The difference in those two numbers will often surprise you. Before we move on, I'm curious. Have you ever been put on a medication after a test result and later wondered whether you truly needed it? Type medication in the comments below. You might be surprised how many people share your experience. Number 4. Routine thyroid screening without specific symptoms. The thyroid gland sits quietly in your neck and regulates nearly every metabolic process in your body. Temperature control, energy levels, heart rate, digestion. It is an extraordinarily important organ. And thyroid disorders, when they occur with real symptoms, absolutely deserve to be identified and treated. But here's the problem. After 70, the normal range for TSH, the primary marker used to assess thyroid function, shifts. What looks like a mildly elevated TSH in a 70-year-old is frequently a completely normal adaptation of the aging thyroid. It is not, in most cases, a signal to begin thyroid hormone replacement therapy. And yet, that is exactly what happens in a significant percentage of older adults whose routine lab panels include a thyroid test. A major longitudinal study published in the New England Journal of Medicine followed adults over 80 with mildly elevated TSH levels. The researchers found that not only did treatment with thyroid hormone not improve quality of life or cognitive function, it was actually associated with a higher incidence of adverse cardiac events. In plain language, treating a number that didn't need treating increased the risk of heart problems. And here's the even more troubling part. Thyroid hormone, when given unnecessarily, accelerates bone loss. In a population already at significant risk for osteoporosis and fractures, this is a serious concern. Research published in the journal Nutrients found that inappropriate thyroid hormone use in postmenopausal women was associated with a measurable reduction in bone mineral density within 12 months of starting treatment. What I recommend is this. If you are over 70 and feeling well, with normal energy, normal weight, and no cold intolerance or unusual fatigue, ask your doctor why a thyroid test is being included in your routine panel. Not because you should refuse, but because you deserve a specific answer. And if a mildly abnormal result comes back, ask whether it falls within the adjusted reference range for your age group, because that question alone may save you from years of unnecessary medication. Number 3, annual mammograms after 75. This one is perhaps the most emotionally charged topic I will raise today, and I want to approach it with the care and respect it deserves. Mammography has saved lives. It has detected cancers early. For women in their 40s, 50s, and 60s, it remains a critically important screening tool. I am not disputing any of that. But after 75, the calculus changes in a fundamental way, and the major medical organizations know it. The United States Preventive Services Task Force currently states that evidence is insufficient to assess the balance of benefits and harms of screening mammography in women aged 75 and older. That is not a ringing endorsement. That is a carefully worded acknowledgement that for this age group, the picture is complicated. Here is why. Mammograms in older women have a higher rate of false positives. And a false positive in a 78-year-old woman does not simply mean a callback appointment, it means a biopsy. It may mean a surgical procedure. It may mean a diagnosis of a slow-growing cancer that would never, under any realistic medical projection, have caused symptoms or shortened her life. But once that cancer is found, the system creates enormous pressure to treat it. And treatment, even for a small, slow-growing cancer, carries real risks in an older adult. The stress alone can be devastating. A study published in the Journal of the American Medical Association followed women over 70 who received false positive mammogram results. Researchers found that these women experienced elevated anxiety and depression scores that persisted for up to 3 years after the negative follow-up confirmed no cancer was present. 3 years of psychological suffering from a test that found nothing real. I remember Margaret, a 78-year-old retired school librarian from Philadelphia. She came to me after her annual mammogram flagged a small cluster of calcifications. She underwent a biopsy, which came back showing a very early, slow-growing type of ductal carcinoma in situ. Her surgical oncologist recommended a lumpectomy. She had the procedure. During the recovery, she developed a post-surgical infection that required hospitalization. She spent 11 days in the hospital. When she came to see me afterward, thin and frightened and confused, she said something I will never forget. She said, "Doctor, I felt completely healthy before that mammogram. I went in for a routine check, and now I feel like I lost a part of myself. This was not a failure of medicine. The doctors involved were doing exactly what the guidelines prompted them to do. This was a failure of a system that had not stopped to ask whether finding that particular thing, in that particular woman, at that particular stage of her life, was truly in her best interest. For women over 75, I strongly encourage a direct, individualized conversation with your physician before continuing annual mammogram screening. Ask whether the potential findings would realistically change your treatment decisions. Ask what your surgeon would recommend if something were found. The answers to those questions should guide your decision, not a blanket protocol. This brings us to number 2. Hit that like button if you're still with me, because we're getting to the most important ones. And subscribe to this channel so you never miss the straight-shooting health information I share every week for adults over 60. Number 2. PSA testing for prostate cancer after 75. The PSA test, which stands for prostate-specific antigen, is a blood test used to screen for prostate cancer. It has been one of the most controversial tests in all of medicine for the past 3 decades. And for good reason. The fundamental problem with PSA screening after 75 is this. Prostate cancer in older men is extraordinarily common. Autopsy studies have consistently shown that somewhere between 40 and 60% of men who die of other causes after age 80 have prostate cancer in their tissue. cancer that never caused a single symptom, cancer that was completely silent, cancer that was never going to shorten their life. But the PSA test cannot distinguish between that silent, irrelevant cancer and a fast-moving, aggressive one. So when an elevated PSA triggers a biopsy, and the biopsy finds cancer, what happens next is a medical system ill-equipped to say, "We found something, but we should probably leave it alone." A landmark study published in the New England Journal of Medicine, known as the PLCO trial, followed tens of thousands of men over 2 decades. The researchers found that in men over 75, PSA screening did not reduce prostate cancer mortality in any statistically meaningful way, but it was associated with a substantial increase in biopsies, and a significant number of those biopsies led to complications, infection, bleeding, and in a small but real percentage of cases, serious urinary complications requiring hospitalization. And then there is the surgery. Radical prostatectomy, the removal of the prostate gland, carries a risk of permanent urinary incontinence of between 10 and 30% in older men. It carries a risk of significant erectile dysfunction of over 60%. These are not rare outcomes. These are expected outcomes. And for a cancer that, in a 78-year-old man, was statistically very likely to never cause any problem at all, those outcomes represent an enormous and completely unnecessary price to pay. I remember James, a 76-year-old retired firefighter from Boston. He had been healthy his entire life, strong, active, still hiking with his grandchildren. His new internist ordered a routine PSA as part of his annual blood work. The number was elevated. A biopsy was performed. It came back positive for a low-grade prostate cancer. His urologist recommended surgery. James trusted the process. He had the prostatectomy. He developed urinary incontinence afterward that required him to wear protective pads daily for over a year. He told me, in one of the saddest conversations I have had in my career, that he had stopped hiking. Not because his legs were weak, but because he was afraid of what would happen if he couldn't find a restroom in time. He said, "Doctor, I went in healthy and came out embarrassed." His exact words. The American Cancer Society and the American Urological Association both now recommend against routine PSA screening in men over 75. The United States Preventive Services Task Force gives PSA screening in men between 55 and 69 AC rating, meaning the decision should be individualized. And for men over 75, the task force recommends against screening entirely. If your doctor is ordering a PSA test and you are over 75, you have every right to ask why, and to ask what the plan is if something is found. Because in most cases, the plan will lead you somewhere you did not expect to go. This brings us to number 1, the medical test that concerns me most for adults over 70. The one that generates more unnecessary procedures, more unnecessary anxiety, and more genuine harm than any other routine screening in this age group. Number 1, aggressive cardiovascular stress testing and cardiac catheterization following mildly abnormal ECG findings. Now let me explain this carefully, because I want you to understand exactly what I'm talking about. When a routine annual physical includes an electrocardiogram, which is an ECG or EKG, that test is reading the electrical activity of your heart. And after 70, it is completely normal for that electrical pattern to show certain minor changes. Changes in the shape of certain waves, slight alterations in rhythm, minor variations that, in a younger heart, might indicate a problem. But in a heart that has been beating faithfully for 70, 80, or 85 years, these changes are often simply the fingerprint of age. The problem is that when these mildly abnormal findings appear on a routine ECG, they very frequently trigger a cascade. The next step is usually a stress test, a treadmill test, or for those who cannot exercise, a pharmacological stress test in which drugs are used to artificially stress the heart. And stress tests in older adults carry their own risks. They are not benign procedures. They can trigger arrhythmias. In rare but real cases, they can trigger cardiac events in people who are otherwise stable. And if the stress test also shows something that looks unusual, the next step is often cardiac catheterization, a procedure in which a thin tube is threaded through an artery in your wrist or groin and guided to the coronary arteries of your heart to look for blockages. Cardiac catheterization is an invasive procedure. It carries a risk of bleeding, a risk of stroke, a risk of kidney damage from the contrast dye used. And in adults over 75 with normal kidney function already in decline, that contrast dye risk is not trivial. A study published in the Journal of the American College of Cardiology found that the rate of adverse events from cardiac catheterization increases substantially with age, with adults over 75 experiencing complication rates 2 to 3 times higher than younger patients. And the most critical finding? In patients who had no symptoms, no chest pain, no shortness of breath, no exercise intolerance, the proportion of catheterizations that found actionable, treatable disease was dramatically lower than in symptomatic patients. In other words, in patients who felt perfectly fine, the test was often finding things that did not need to be found. I remember Dorothy, a 79-year-old retired music teacher from Chicago. She came for a routine physical feeling well. Her ECG showed what her internist described as a nonspecific T-wave abnormality. She was referred for a stress test. The stress test showed what the cardiologist called possible ischemia. She was sent for cardiac catheterization. During the procedure, she developed a small hematoma, a collection of blood, at the access site in her groin. It required monitoring. Her kidney function dipped afterward from the contrast dye. She spent 3 days in the hospital for observation. The catheterization found no significant coronary artery disease. Her arteries were, as her cardiologist put it, pretty good for her age. She went home. She called my office the following week. She was exhausted and frightened and confused. She said, "Dr. Holloway, I felt completely fine before that ECG. How did I end up in the hospital for 3 days?" I didn't have an easy answer. Because the system had done exactly what it was designed to do. Every step had followed logically from the one before it. And yet the cumulative result had been 3 days of hospitalization, a bruised artery, reduced kidney function, and genuine fear in a woman who had walked into a routine physical feeling completely healthy. This is the cascade effect. And it begins with a mildly abnormal ECG in a person with no symptoms. What I advise my patients is this. If you receive an abnormal ECG result and you have no symptoms, meaning no chest pain, no unusual shortness of breath, no dizziness, no palpitations, push back on the automatic next step. Ask whether your specific finding is the kind that requires further investigation, or whether it may be a normal variant for your age. Ask whether watchful waiting with lifestyle monitoring is a reasonable alternative. Ask what, realistically, would be done if a blockage were found. Would stenting or bypass surgery be appropriate for someone with your overall health profile? Because the answer to that question should drive whether looking for a blockage in the first place makes any sense. You are not broken. The system is simply not designed to pause and ask the questions that matter most when it comes to caring for a 75 or 80-year-old body. Now let me give you the practical action plan that comes from everything I have shared today. First, before any screening test is ordered, ask your doctor one simple question. What will we do if we find something? If the answer leads to a chain of procedures that you would not be appropriate candidates for, or that you would not consent to, the test may not be serving your interests. Second, ask about your specific risk profile. Standard guidelines are written for populations. You are an individual. your family history, your current symptoms, your existing medications, your kidney function, your bone density. All of these things should shape which tests make sense for your specific body right now. Third, bring someone with you to appointments. Research published in Frontiers in Aging found that patients who attended medical appointments with a trusted companion retained significantly more information, asked more questions, and were less likely to agree to unnecessary procedures out of anxiety or confusion. A second set of ears changes everything. Fourth, look up the United States Preventive Services Task Force recommendations for any test your doctor proposes. This is a federally funded, independent panel of medical experts whose sole job is to evaluate the evidence for and against medical screenings. Their recommendations are available for free online. They are written in plain language, and they will tell you clearly whether a particular test has strong evidence, weak evidence, or no evidence of benefit for your age group. Fifth, and most importantly, do not let a test result become your identity. A number on a lab report is data. It is not a sentence. It is not a diagnosis until it is put in the context of everything else about who you are and how you feel and what your goals are. Within the first week of applying this kind of thinking, my patients tell me something shifts. They describe feeling less like a passive participant in their own medical care and more like a partner in it. That shift matters. That shift protects you. Within a month of having these conversations with your doctors, you will likely find that some tests simply stop being ordered. That the annual appointment becomes more focused on how you feel and less on a checklist of procedures. That you leave the office with more clarity and less anxiety than you had before. And here's the thing that I hope you carry with you long after this video ends. You are not a collection of numbers and test results. You are a person with a history, with relationships, with things you love to do, and people who love you. The goal of medicine is not to find everything that can be found. The goal of medicine is to help you live as fully and as independently as possible for as long as possible. And sometimes the bravest thing a doctor can do is order fewer tests, not more. So let me give you my challenge. Before your next medical appointment, write down the tests your doctor has recommended or typically orders for you. Then, for each one, write down the question. What happens if something is found? Bring those questions with you. Say them out loud. You have that right. You have earned that right. And now I want to hear from you. Which of these 5 tests surprised you most? Have you or someone you love experienced the cascade effect I described today? Share your story in the comments below. I read every single one. Because your experience matters, and it may help someone else ask the right question at the right time. If this video gave you something valuable, please hit that like button. It helps this information reach more people who need it. Subscribe so you never miss what we share here every week. And share this video with someone you love who is over 70. Because the most important medical decisions of their life may be coming up, and now they will be better prepared to make them wisely. Because remember, aging does not mean surrendering control of your health decisions. It means you have earned the wisdom to make them better than ever before. Take care of yourself.